Every 34 seconds, someone in the United States develops dementia. By the time this video ends, more than 100 people will have received that diagnosis. And here is the part that keeps me up at night. For a significant number of them, the trigger was not aging. It was not genetics. It was sitting in a medicine cabinet, taken every single day, bought at a drugstore or prescribed by a well-meaning doctor who had 12 minutes and a full waiting room. I am a physician, and after more than 15 years working with patients, I have watched people lose their sharpest years not to an unavoidable disease, but to a reaction nobody warned them about. I have sat across from families who told me their mother was fine 6 months ago, sharp as a tack, and now she cannot remember what day it is. And when I looked at the medication list, the answer was right there on the page. Today, I am going to walk you through 9 popular medications that have been linked to rapid cognitive decline. Some of these you will recognize immediately. Some of them you probably do not think of as powerful drugs at all. A few of them are sold without a prescription for less than the cost of a cup of coffee. That is exactly why this conversation matters. Because nobody sat you down and explained what these molecules do inside a brain that is already working harder than it did at 40. Before we go further, everything I shared today is educational. Nothing here replaces your doctor. You should never stop a medication on your own. What I want is for you to walk into your next appointment armed with the right questions. That is the whole point. Now, here is what I need from you before we start. Tell me in the comments how old you are and which medications you take. I read those comments, and the age and health profile of this audience shapes exactly what I cover in the next video. So take 30 seconds and leave that for me. We are going to count down from 9 to 1, because number 1 on this list is the one I see most often overlooked. The one that is sitting in millions of homes right now being taken every single night. And by the time we get there, I want you to understand exactly why it is the most dangerous of all. But first, let me give you the mechanism that runs underneath every single drug on this list, because once you understand it, everything else will fall into place. Your brain runs on a signaling system. Neurons talk to each other through chemicals called neurotransmitters. The one that matters most for this conversation is acetylcholine. Acetylcholine is the currency of memory and attention. When your neurons want to encode a new memory, when they want to hold a thought, focus on a face, they spend acetylcholine to do it. Now here's the problem. A massive category of commonly used drugs blocks acetylcholine. These are called anticholinergic drugs. Think of it this way. Imagine your brain is a busy telephone exchange, and acetylcholine is the signal that connects the calls. Anticholinergic drugs are like cutting the phone lines. The messages do not get through. Do that for a day, you feel foggy. Do it for a year, the lines start to fray permanently. The brain compensates for a while, and then it cannot. Not every drug on this list is anticholinergic, but many of them attack cognition through related pathways: sedation, disrupted sleep architecture, nutritional depletion, or inflammation. I will name the mechanism each time so you always know what you are dealing with. Starting at number 9. Number 9 is diphenhydramine. You know it as Benadryl. You also know it as the active ingredient in ZZ Quil, Unisom sleep tabs, Tylenol PM, and dozens of store-brand sleep aids. It costs about $4 or $5 for a large bottle. It is sitting in most American households right now. That familiarity is the danger, because diphenhydramine is one of the most potent anticholinergic drugs that exists, and it passes the blood-brain barrier with ease. Here is the mechanism. Diphenhydramine walks into your brain and cuts the acetylcholine lines we just talked about. One night, you feel groggy the next morning. That is the short version. The long version, the one that applies to people who reach for this every night to fall asleep, is more serious. Research published in JAMA Internal Medicine, involving data from more than 3,000 seniors tracked over a decade, found that cumulative anticholinergic drug use was significantly associated with an increased risk of developing dementia. The higher the cumulative exposure, the higher the risk. The key word there is cumulative. Every night adds to the total. To be clear, if you take diphenhydramine once during allergy season, that is a very different conversation than taking it every single night for years. But I see patients who have done exactly that, often because no one offered them a better option. If you are using this for sleep, bring it to your doctor. There are safer approaches, and I want you to have that conversation. Never stop it abruptly, without guidance, if you have been taking it regularly, but please bring it up. Number 8 is promethazine, brand name Phenergan. This is prescribed for nausea and vomiting, for motion sickness, sometimes after surgery. It is also anticholinergic. and it is sedating in a way that is particularly harsh on an older nervous system. The brain over 60 is already running on a slightly tighter margin when it comes to neurotransmitter reserves. Promethazine does not know that. It blocks indiscriminately. Short-term use for a specific situation is usually a clinical decision with acceptable trade-offs. Repeated or prolonged use is a different matter. If you have been prescribed this regularly, ask whether there is an alternative that carries less cognitive load. Never stop it on your own. Bring the question to your provider. Number 7 is oxybutynin, brand name Ditropan. This one is prescribed for overactive bladder, and it is extremely common in adults over 60. Tens of millions of prescriptions are written for bladder control medications every year in this country. Oxybutynin is one of the older ones in this class, and it is strongly anticholinergic. The reason it controls your bladder is precisely because it blocks the acetylcholine receptors that make your bladder muscle contract. Unfortunately, it does not only block those receptors in the bladder, it crosses into the brain and blocks them there too. I have had patients come to me convinced they were developing Alzheimer's disease. Memory lapses, difficulty concentrating, confusion that seemed to come on gradually over 6 to 12 months. And in more than one of those cases, oxybutynin was on the medication list. There are newer bladder medications with far less anticholinergic activity in the brain. Mirabegron is one example. If you or someone you care for is taking oxybutynin, and this is a specific name question to bring to the prescribing doctor, is there a bladder medication with a lower anticholinergic burden? That is the phrase to use. Write it down. Number 6 is amitriptyline, brand name Elavil. This is an older antidepressant, a tricyclic, meaning it belongs to a class developed in the 1950s and 60s. It is still prescribed today, sometimes for depression, sometimes for nerve pain, sometimes for migraine prevention, sometimes for sleep. It is cheap and familiar. It is also one of the most anticholinergic medications that exists. When I look at the anticholinergic cognitive burden scale, which is a clinical scoring tool used to assess a patient's total anticholinergic load, amitriptyline sits at the highest level of concern. The problem is that many of the conditions it is prescribed for are real and painful. Nerve pain is debilitating. So this is not about blame. It is about asking whether a newer agent with a cleaner cognitive profile could do the same job. Never stop amitriptyline on your own. Stopping this medication abruptly can cause serious withdrawal effects. But having an honest conversation with your doctor about your total anticholinergic burden, especially if you are already on other medications from this list, is exactly the kind of conversation that can protect your brain. Now, I want to pause here for a moment, because we are about halfway through this list, and I want to recognize something. Every single drug we have covered so far shares the same mechanism. They all cut the same phone lines. And we have not even gotten to the ones that attack through different pathways, the ones that disrupt sleep so deeply that the brain cannot clean itself, or the ones that quietly drain the nutrients your neurons depend on. Those are coming. Before we get there, I want to say something about this channel. The work I do here explaining the why, giving you the mechanism behind the medicine, is the work I never had enough time to finish in a 12-minute appointment. If you want everything I wish I had time to cover in the office, in one place, including the full guide to medications worth questioning, the foods that protect brain tissue, and the warning signs your body uses before a crisis, it is all collected in the Complete Senior Health Vault. That is the 3-guide pack built for patients over 60 and the families who take care of them. The link is in the description, and you can scan the code on your screen right now to go directly there. It is educational material, not a replacement for your doctor, but it is the kind of plain English resource that helps you walk into that appointment with the right questions already written down. Now, back to the list, because what comes next is the one nobody talks about. Number 5 is paroxetine, brand name Paxil. This is a modern antidepressant, an SSRI, and this one surprises people because SSRIs are generally considered to have a much cleaner safety profile than the older antidepressants. Most of them do, but paroxetine is the outlier. Within the SSRI class, paroxetine has measurable anticholinergic activity that the others do not. It is not as potent as amitriptyline on this axis, but when you add it to a medication list that already contains other anticholinergic drugs, it tips the balance. If you are taking an antidepressant and you are concerned about cognitive effects, the most important thing is to never stop it on your own. Discontinuing paroxetine abruptly is associated with significant withdrawal symptoms, but asking your prescriber whether your total anticholinergic burden has been reviewed and whether paroxetine is still the right choice for your profile is a reasonable and important question. Number 4 is lorazepam and the benzodiazepine family broadly. Lorazepam is the brand name Ativan. You also know this family as diazepam, which is Valium, and alprazolam, which is Xanax. These are prescribed for anxiety, for panic, for insomnia, sometimes for muscle spasms. They work by amplifying a calming signal in the brain called GABA. Think of GABA as the volume knob. Benzodiazepines turn the volume all the way down. That feels like relief when you are in crisis. But used long-term, especially in older adults, they create a problem that is distinct from the anticholinergic mechanism. Here's what they do to the brain over time. They disrupt the architecture of sleep. You may fall asleep faster, but you lose the deep, slow-wave sleep and the REM sleep that are essential for memory consolidation. More critically, slow-wave sleep is when your brain runs its glymphatic system. Think of the glymphatic system as the overnight cleaning crew. While you are in deep sleep, cerebrospinal fluid flushes through the brain and carries out metabolic waste, including amyloid beta, the protein that accumulates in Alzheimer's disease. Benzodiazepines suppress that cleaning cycle. Night after night, the waste builds. Research published in the British Medical Journal found that benzodiazepine use was associated with an increased risk of Alzheimer's disease, and that the risk was higher with longer duration of use. The relationship was dose and duration dependent. If you are currently taking a benzodiazepine every night, this is a serious conversation to have with your doctor. Tapering off benzodiazepines must be done slowly and under medical supervision. Never stop them on your own, but getting off them with guidance is one of the most protective things some of my patients have done for their cognitive future. Quick pause here. If this is connecting the dots for you, tap that like button. It genuinely helps this reach more seniors who need it. And if someone in your family is worried about their memory or their medications, please send them this video right now. They deserve to have this conversation too. Number 3 is metoclopramide, brand name Reglan. I want to spend real time here because this one is less discussed and more dangerous than most people realize. Metoclopramide is prescribed for gastroparesis, which is delayed stomach emptying, and for reflux and nausea. It works by blocking dopamine receptors in the gut and the brain. Dopamine, like acetylcholine, is a neurotransmitter. It does not just govern pleasure and motivation, it governs motor control. It is the chemical that goes missing in Parkinson's disease. When metoclopramide blocks dopamine receptors in the brain, it can cause something called tardive dyskinesia, which is involuntary, repetitive movements, and it can trigger or worsen Parkinson's-like symptoms. In older adults whose dopamine systems are already less robust than they were at 40, this risk is amplified. Long-term use of metoclopramide, meaning more than 12 weeks, carries a black box warning from the FDA, precisely because of the risk of tardive dyskinesia. That black box warning is the strongest warning the FDA issues, and yet I have seen patients on this medication for years without anyone revisiting whether it was still appropriate. If you are taking metoclopramide, the duration of use is the critical question. Bring it to your provider and never stop it without guidance. Number 2 is Zolpidem, brand name Ambien. This is the most commonly prescribed sleep medication in the United States, and its effects on brain function in older adults are a genuine clinical concern. Zolpidem is not technically a benzodiazepine, but it works on the same GABA receptors. The same mechanism applies. It sedates, but it does not create restorative sleep. In older adults, the drug stays in the system longer than it does in younger people because the liver processes it more slowly. That lingering presence creates next-day cognitive impairment, contributes to fall risk, and, used chronically, compounds the kind of sleep disruption that prevents the brain from cleaning itself at night. The FDA has specifically warned that women and older adults are at higher risk for morning impairment after taking Zolpidem, and has recommended lower doses for older patients. Many patients I have seen were still on the standard adult dose, not the adjusted dose, for years. If you are on Zolpidem nightly, the question to ask your doctor is this: has my dose been reviewed for my age? And is there a cognitive behavioral approach to sleep that we could try first? Sleep hygiene and behavioral interventions have evidence behind them that matches or exceeds medication for chronic insomnia in older adults. Never discontinue Zolpidem on your own, but begin that conversation. And now we arrive at number 1. I told you at the beginning that this would be the one most often overlooked, the one taken every single night, the one sitting in millions of homes. It is not a prescription drug. It is not a drug most people think of as powerful at all. It is proton pump inhibitors. You know them as omeprazole, brand name Prilosec; esomeprazole, brand name Nexium; lansoprazole, brand name Prevacid. These are among the most widely taken medications in the United States. They are sold over the counter. They are taken daily by a vast number of adults over 60 for reflux, for stomach protection, for ulcer prevention. Many people take them for years without ever being told they were designed for short-term use. Here is the mechanism that earns them the top spot. Proton pump inhibitors work by dramatically reducing stomach acid. That is what they are designed to do. But stomach acid is not only for digesting food, it is essential for absorbing certain critical nutrients, specifically magnesium, B12, and calcium. When you suppress stomach acid chronically, you impair absorption of all three. Now here is why this matters for your brain. Vitamin B12 is the neuron maintenance worker. Your neurons are wrapped in a protective sheath called myelin, and B12 is required to maintain that sheath. When B12 drops, the myelin degrades. Signals slow down. Cognitive function falters. The insidious part is that B12 deficiency develops slowly, often over years, and its symptoms, memory problems, difficulty concentrating, fatigue, mood changes, are indistinguishable from early dementia. I have had patients who were told they had dementia, who had profound B12 deficiency, and when we corrected it, they improved. Not every case, but enough cases that every patient on a long-term proton pump inhibitor should have their B12 and magnesium checked routinely. Research published in JAMA Neurology has linked long-term proton pump inhibitor use to an increased risk of dementia. The mechanism is consistent with B12 depletion and, separately, with the role these drugs may play in the gut-brain axis. The gut and the brain communicate constantly through the vagus nerve, and the gut microbiome, which is profoundly altered by long-term acid suppression, influences neuroinflammation in ways we are still mapping. If you have been on a proton pump inhibitor for more than a year, ask your doctor to check your B12 and magnesium levels. Ask whether you still need the medication, or whether a lower dose or a different acid management strategy might work. And never just stop it abruptly, because stopping a proton pump inhibitor suddenly can cause a rebound of acid production that is worse than what you started with. This is a conversation, not a cold stop. Now, I want to tell you about a patient I will call Margaret. Margaret was 72 years old from Columbus, Ohio. Her daughter brought her to see me because over the previous 8 months, Margaret had become confused in ways her family described as alarming. She was forgetting appointments. She was repeating questions within the same conversation. Her doctor had suggested they consider a dementia evaluation. When I looked at Margaret's medication list, she was on a proton pump inhibitor she'd been taking for 4 years for reflux. She was on oxybutynin for bladder control. And she was on diphenhydramine every night for sleep. 3 of the 9 medications on this list, all running simultaneously, creating a cumulative anticholinergic burden and a B12 deficiency that her labs confirmed. Her B12 was critically low. We did not start with a new prescription. We started by working with her primary care physician to taper the diphenhydramine and replace it with a behavioral sleep protocol. We transitioned her bladder medication to one with a lower anticholinergic burden. We added B12 supplementation and monitored her levels. Within 3 months, her daughter called me. She said, "Mom finished a crossword puzzle yesterday for the first time in a year." She remembered the names of all her grandchildren without being prompted. She carried her own groceries in from the car. It was not a miracle. It was a medication review that should have happened sooner. Margaret's story is not rare. It is far too common. And the reason it happens is not malice. It is that the system does not have a mechanism for regularly reviewing the cumulative burden of everything a patient is taking together. Individual drugs are evaluated. The stack is not. That is what you have to advocate for. So here is what I want you to do tonight. 5 steps starting today. First, write down every medication you take, including over-the-counter drugs, sleep aids, allergy pills, antacids, everything. Not just the prescriptions, everything. Second, look for overlaps with this list. Diphenhydramine in any form, sleep aids, allergy medications, bladder medications, especially oxybutynin, older antidepressants, any benzodiazepine, long-term proton pump inhibitors, metoclopramide. Third, ask your doctor for what is called a medication review, specifically requesting that your total anticholinergic burden be assessed. Use those words, write them down before the appointment. Fourth, ask for a B12 and magnesium lab check if you have been on a proton pump inhibitor for more than a year. Fifth, if you have any loved one showing signs of cognitive change, look at the medication list before accepting the diagnosis at face value. Not because the diagnosis is always wrong, but because a reversible drug-induced cause deserves to be ruled out first. If you want to go deeper than this video has time for, all 3 of my plain English guides are in one place. The full medication list to question, the foods that protect brain tissue, and the body signals to watch after 70. Scan the code on your screen or tap the link in the description below. It is the resource I built for exactly the kind of conversation we just had, because the 12-minute appointment was never going to be enough. Now, before you go, here is what I need from you. Tell me in the comments. Will you ask your doctor for a medication review this week? Just the words, I will ask. Because that one conversation armed with what you learned today might be the most important appointment you have had in years. And there is one more place your body hides its warnings, one that doctors almost never check at a routine visit, and it can tell you whether this process has already begun. That is the next video. Stay sharp, and I will see you